السوق بس مش واضح.
Chair Wendy DiMartini, MRI, and Peter Eby is the Audit and Outcomes Monitoring Sub-Chair. So I want to tell you a little bit about the updates. So we are expecting every section is being reviewed by all of us, and we're looking at the evidence that's in the literature that's more current, expert consensus, also if there isn't enough evidence, and also expert opinion. Every subcommittee has had their marching orders to get the work done, and we've met for over a year. This started some time ago, and then the sub-chairs of each section have been meeting for over a year, and now we have additional groups of experts that are being asked to review what the changes are and what the editing that we've done is. We want to optimize, the format and highlight new content, but we have to make sure that we all understand that everything is preliminary and the information that we are presenting may change as new information comes in and new edits come in. So nothing is finalized. This is all preliminary. So what we have these major indication categories for every section. So we're going to have major indications and then subcategories, and also any relevant history that's there to be reported. So asymptomatic screenings, whether they're elevated risk, whether they have dense breasts or they just completed treatment for breast cancer, and also other history like a gene mutation and what the cancer risk is. Now, if it's a diagnostic patient, of course, the clinical findings and then imaging findings, the follow-up that we're recommending, if it's a BI-RADS 1 or 2, like a year, or if it's a BI-RADS 3, short-term follow-up, if there are follow-up after a biopsy, and whatever other clinical findings are important in the relevant history and other imaging findings from other testing. Now, if the patient is a diagnostic and is going through cancer treatment, we want to have the subcategory to say whether this is an extent of disease exam prior to definitive surgery, or if it's for response to treatment as they're being treated for their cancer diagnosis. Information such as location and size of the cancer on the prior imaging also is important. So we want the clinical indications to be as much as we can modality neutral. And this will be very important for all of us as we do research and we have collections that we want to be able to report on. And so we want to be able to improve national benchmarks and medical outcomes. So we will definitely, as we make these neutral to the modality, we'll have more information that we can collect. So if it's a patient that's a diagnostic patient, we will obviously give information such as, is it response to treatment for current breast cancer? Is it a BI-RADS 4 or is it a 5? And so we will start with what is the diagnostic reason and then end with the assessment category. Of course, we'll have the follow-up categories BI-RADS 3, and that may end as a 4 because we're going to biopsy, or a 2. So we want to give more detail to the clinical indications. The structured reporting is also going to be helpful for the different vendors that are working on this, and for our coders and our billing departments, and also to be able to identify from the reporting method of detection. This has been important for us to be able to say, was a screening exam, whether it was a screening MRI or screening breast ultrasound for dense breasts, or screening mammogram, whether digital or tomo. And so we do want to be able to have these structured clinical indications that will make our life a bit easier to be able to identify what the patient's coming in for. So this is the mammography subcommittee, and I am the sub-chair, like I said to you, and I have the pleasure of working with Dr. Poplack, Dr. Grimm, Dr. Friedwald, and Dr. Sum. So what we did with the lexicon, we updated and expanded, including predominantly digital mammography. As you remember, the previous mammography section had some film still. So we upgraded to digital, but also added quite a bit of digital breast tomosynthesis and also synthetic mammogram images. So we've reviewed all the images and updated them. The captions will have the dominant finding, and then in many cases we add additional descriptors if there's more than one finding that describes the abnormality. Wherever we had pathology, whether from core biopsy or surgery, it's included, and then the management is based on the most suspicious finding. So we've added a lot on tomosynthesis in the guidance chapter. We want to be able to help the interpreting radiologists manage clinical scenarios that occur and to improve consistency across breast imaging practices. Now, if you notice that the definition for tomosynthesis, we've expanded it to include the lower recall rate and also higher cancer detection. And because we can see the margins of a mass, even the shape of the mass, we can localize lesions better in the breast, so that's been expanded on. And something is called a lesion, even if we only see it on one mammographic projection, which the supplement that we have worked on previously for tomosynthesis did not say that, but now even on one view, if we see something, because of the higher conspicuity of identifying lesions with tomo, we want to be able to say, yes, it's real, we have to work it up. And also, you may not need the additional mammographic views in many cases because it is much easier to identify something. Now, the previous edition, the 5th edition, discussed breast density, and it transitioned from just a percentage to any area of the tissue that may be dense and the likelihood that the overlying tissue may obscure cancer. So this was accepted in our 6th edition, and so we should be able to upgrade anything, any area of dense tissue to that, even if the rest of the tissue is scattered or has the less dense category. So you see on this mammogram, the right CC is pretty safely in the scattered category, but the tissue is asymmetric. So the left breast has an area of asymmetric dense tissue, an island of dense tissue that may obscure, a mass. So we obviously will upgrade this to heterogeneously dense. Now we streamlined a lot of the wording for the breast density, getting rid of some of the redundancy. But unfortunately, even though we streamlined to what you see there, almost entirely fatty, scattered tissue, heterogeneously dense, and extremely dense, the FDA came out in March telling us exactly the required language for the wording of the categories of breast density for all reports in all states in the United States. So we had to go right back to where we were and include the breasts are almost entirely fatty. There are scattered areas of density, and the breasts are heterogeneously dense, which may obscure small masses, and the breasts are extremely dense, which lowers the sensitivity of mammography. So risk and breast density, we added that there are 2 reasons, obviously reduced mammographic accuracy and also the inherent breast cancer risk. So that's we are familiar with the impact of how breast density may reduce mammographic accuracy because of masking. But now we also discuss inherent risk. Having dense breast does confer you a higher risk of developing breast cancer. And we put some odds ratios in there that kind of make sense in comparison to scattered tissue and also in comparison if it's heterogeneously dense or extremely dense, and the slightly higher risk for breast cancer there. We did change some of the mass descriptors. We added lobular in the shape, that has been reinstated. And because we had microlobulate in the margin, we eliminated it because it was used infrequently. This is not final. We are still discussing these descriptors. We also removed popcorn-like calcifications under the benign calcifications, and we replaced that and put it in coarse. You know, most of the time the popcorn calcification will be seen with the calcified fibroadenoma. And, you know, of course, we want to be careful that we're not calling something coarse that may be coarse heterogeneous. So we obviously will be looking for that to make sure that these are not mixing together. Punctate, very small round calcifications, less than 0.5 millimeters, and that's been removed because of the impracticality of measuring these individual calcifications. And now we put them under the round calcification descriptor. We removed milk of calcium and put that instead as layering. Layering calcifications may be crescent-shaped, curvilinear, or semilunar, and they will look different, obviously, on the medial lateral oblique view versus the 90-degree lateral medial lateral view. So we definitely would want to evaluate calcifications with the 90-degree lateral medial lateral views. On the CC view, these will typically be round and smudgy. Asymmetry, the developing asymmetry descriptor has been discussed quite a bit, and at this point it's been removed, as that really speaks to a temporal relationship, something developing, and we don't have that for calcifications or masses, and we're currently discussing this. Solitary dilated duct, in the 5th edition, this was endorsed, that tissue diagnosis is recommended if you have a solitary dilated duct. However, the newer literature supports how rare this is, and if there are no suspicious imaging findings, and if the patient does not present with any clinical symptoms that are suspicious, then this is benign. So very low likelihood for malignancy, we can consider that benign. Obviously, if there's discharge or something else, the patient's symptomatic, you have to work that out. For breast ultrasound, the big findings are that there was introduction of a new element in the associated features, and that's called echogenic rind. That disrupts the texture of normal tissue surrounding a mass and represents desmoplastic reaction or peritumoral edema. This is not echogenic rind. This is a smooth pseudocapsule, which we may typically see with a fibroadenoma, but this is echogenic rind. And this, according to some of the literature, it has a high PPV for malignancy, and biopsy, unless you have already biopsied and it's proven benign, fat necrosis can fool us into thinking that this is a malignancy. So basically, we are including echogenic rind in the measurement of the mass, and that correlates well with histology and also the, for the measurement of the true measurement of the lesion. As ultrasound has improved and the technology has had significant advances, there's obviously awareness of things that don't quite qualify as a mass, and so non-mass has been introduced that may be identifiable in 2 planes or predominantly visualized in 1 plane, but it doesn't have a definable shape and margin, and it tends to be cancer at DCIS. So we look for echogenicity. We also look for distribution with these non-mass areas, but shape and margin we're not going to be able to find. Orientation can be parallel and non-parallel. So some of the literature has shown that if you have other things like echogenic rind, architectural distortion, calcifications, hypervascularity, all that suggests malignancy. If you have cysts, it suggests benign. But obviously, if you have these associated clinical variables, like a palpable mass, that will increase your probability of malignancy or a nipple discharge. Lymph nodes have been also included in the ultrasound section, really defined more. It's been expanded. intramammary lymph nodes, axillary, internal mammary, and supraclavicular. And also the cortical-hilar relationship has been expanded on. Breast MRI, we are familiar with, obviously we discussed it already, the modality neutral indications. Now, all of this, the clinical information has been expanded on acquisition parameters, focus has been removed, mass descriptors updated, the lymph node section has been, enhanced, and BI-RADS 3 and frequencies, and also BI-RADS 4 now includes A, B, and C. And so a lot of things have been included in the BI-RADS updates. So the most important thing for the structured clinical indications will be asymptomatic screening for those patients that are higher risk, because of genetic mutation or family history of dense breast or completed treatment for breast cancer, or for a newly diagnosed breast cancer patient, that's the majority, or response to treatment of a newly diagnosed breast cancer patient. So use of comparisons, priors are important. We may not need all the MRIs. MRI can stand on its own, but if you have it, whether it's a prior MRI or other imaging studies, important to have, and also put that in our report for correlation. Now, the acquisition parameters, we define as standard full protocol for contrast enhanced as usually 2 post-contrast exams, and the abbreviated is shorter, typically less than 10 minutes, and has at least 1 post-contrast series. Now, also some changes here. The name of the post-contrast series at the 60 to 120 seconds instead of initial to peak. And for diffusion weighted complement, we mentioned to our current, contrast enhanced MRI, but research still, and there's no BI-RADS reporting guidelines for this at this time. Focus has been removed because we can call it a small mass. Most of these many dots of enhancement that we see are benign, and small and focal non-mass enhancement, all of this now we're going to characterize together. And there was such a discrepancy in how focus was used across practices, it was felt better to be removed. Lobular has been added, which is a few gentle obtuse undulations, and it was included within the oval previously in the current edition. And we wanted to be consistent by adding lobular, and margin that was irregular was changed to uneven because irregular is a mass shape descriptor. The T2 hyperintensity for masses descriptor has been added and enhanced. So we talk about oval, circumscribed, and homogeneous internal enhancement as something that may have a very low probability of malignancy, especially with dark internal septations. And really should be assessed and reported as we identified. So some of it is subjective. So if it's uniformly bright, T2 bright, normal, obviously that may be a lymph node. We did increase the section on lymph nodes here and discuss intramammary, axillary, and internal mammary, and whether they're normal or abnormal, similar to the other subsections that have added more on lymph nodes. It is subjective how you look at lymph nodes on MRI. It's not like in ultrasound when we look at asymmetric cortical thickening, that's not validated for MRI. So sometimes very small or very round lymph nodes are very normal. So we describe where they are, and we want to describe our axillary lymph nodes based on the pectoralis minor for level 1, 2, and 3, and help the surgeon as much as we can. For the BI-RADS 3 categories, so far we've had, we reviewed the published literature, and there are a lot of studies that we can say that BI-RADS 3, you're going to give it if it's a malignancy rate less or equal to 2%. Desirable goal really for the frequency of use should be less or equal to 5% of your exams. And you want to be cautious in non-baseline examinations when you're using it. You got to look at those priors to see how they look like. So BI-RADS 3, there's been some articles that have come out that you can see in the Journal of Breast Imaging there. So you have to go with expert opinion given the limited data. And we want to audit our BI-RADS 3 practice with MRI, and certainly this would support a prospective multi-site trial. So BI-RADS 4 has now been subdivided for A, B, and C to really look at mammogram and ultrasound. So we added it for MRI. The malignancy rate should be similar to mammogram and ultrasound. That will really help us do a meaningful audit for red path correlation. So for assessment BI-RADS 6, findings that we know have had a biopsy and they're proven malignancy prior to surgery. Even if there's no enhancement at the site on MRI, we still are going to call this a BI-RADS 6. And these are new definitions to really help us with additional ipsilateral findings or even contralateral findings. Now, if you have an additional lesion and it's less than 2 centimeters from the known malignancy, and you may now want to, if it doesn't change the extent of the cancer, doesn't change clinical management, then you're going to leave that as an additional BI-RADS 6 finding. We want to avoid using satellite nomenclature, so we want to get rid of that satellite name. But if you have an additional ipsilateral finding that's more than 2 centimeters away from the known cancer, or it increases the extent of the tumor more than 2 centimeters, and it's going to change management, like in this patient, we know that we have a biopsy-proven malignancy, but then we have non-mass enhancement over 7 centimeters. This may now be a mastectomy for the patient. Then you're going to call that additional ipsilateral finding as a BI-RADS 4 or 5 and recommend additional biopsy. So laterality of lesions has been defined more. We want to be consistent with mammography and ultrasound, clocked face, depth, and distance from the nipple. Now for the auditing and outcomes monitoring, it has a new name. It's no longer follow-up and outcomes monitoring, it's auditing outcomes monitoring, but with the same mission. And really the important things here are for the updates, benchmarks for 2D mammography, tomo, ultrasound, and MRI, what not to audit, and regardless of the modality, what's the screening? That's a patient without any symptoms or any imaging findings or any signs that we think of cancer. Diagnostic is someone that has symptoms or findings. So a negative exam then means we're not taking any additional action. It's a BI-RADS 1 or 2 in the screening population. A positive exam is a 0, 3, 4, or 5. But in the diagnostic world, if you're not getting a tissue diagnosis, so BI-RADS 1, 2, or 3, that's a negative, and tissue diagnosis is recommended for the diagnostics is a 4 or 5. If you are going to recommend anything that's in an interval shorter than whatever your screening interval is before the next routine screening, then that is no longer a screening exam. If you're archiving additional images, whether it's an ultrasound, a screening ultrasound, or you've done additional images, and you're looking at those to decide if the patient is normal or not or benign, then that's a positive screening examination. So we want to be very clear of what we call screening and diagnostic. So if you're adding additional diagnostic images, that's no longer a screening. If you're acquiring and archiving additional images prior to the next routine screening exam, that's no longer a screening, whether it's the same day the patient comes back or a different day. And a diagnostic exam is you're doing additional images beyond the standard screening protocol. So we've added charts and flow charts to help with how to do the screening audits, which I think will be very helpful for people and also for the diagnostic audit. The BWEP is the benign with upgrade potential, LCIS, ADH, ALH. We took out peripheral duct papilloma, now it's in the benign. Phylloides stayed. Radial scar or complex sclerosing lesion is now in the benign category. Flat epithelial tibia has stayed. So we're adding BI-RADS 3 to the basic audit because we want to encourage collections and publications for data for ultrasound and MRI especially. And we have very nice flow charts added about how to collect and how to do your BI-RADS 3 audit and how it becomes more meaningful. Extent of disease. This is obviously very important, especially for MRI, for BI-RADS 6. These are, you know, they don't technically have to be audited, but we do want to be able to publish data, so we do need a consistent framework and definitions at the time of the finding. So we do want to be very clear about what to do for extent of disease. Any audit that you will be doing, you know, we want to standardize the abnormal interpretation rates and what's a PPV2, what's a PPV3, what's an additional cancer detection rate. So those are all very important things that we want to know for every diagnostic extent of disease breast MRI exam that we do. So the initial method of detection, we've really been working hard to add that because currently most of our registries don't collect whether the cancer was diagnosed in screening or diagnostic. So we want to add that information. So we want to know if it was a screening, digital mammography, contrast enhanced, ultrasound, or whether it was diagnostic, patient-driven, or clinical physician-driven. So we want to improve auditing overall for the screening and diagnostic patients, and because we know that will improve patient care. So that will update a lot of the benchmarks that now we follow and really improve the standards. So comments are really encouraged, and I do want to thank you for your time.
Thank you, Professor Destounis. Questions will be